Question 1. To what degree does the linear quadratic LQ model explain the biological response of tissues to varying fractionation schedules in radiotherapy? A. It assumes tissue responses are independent of dose per fraction. B. It predicts that late responding tissues have a low AB ratio, making them more sensitive to changes in fractionation. C. It suggests all tissues respond identically to fractionation changes. D. It indicates that increasing dose per fraction improves tumor control in all scenarios. Answer. Correct answer. B. Explanation. The linear quadratic model LQ model helps predict the biological effect of radiation by incorporating both single event linear and double event quadratic B components of cell damage. The AB ratio is crucial. Early responding tissues, e.g. tumors, generally have high AB ratios 10Gi, whereas late responding tissues, e.g. spinal cord, have low AB ratios 2-3, making them more sensitive to fraction size. Thus, hypofractionation may improve tumor control while sparing normal tissue, depending on AB values. This principle underpins many current fractionation strategies in radiotherapy. ICAP Report 103, Joyner and Van der Kogel, Basic Clinical Radiobiology. Question 2. When faced with a patient like MS, Patel, a 65-year-old with type 2 diabetes and chronic kidney disease, ECFA 38 mmN, who requires a contrast-enhanced CT abdomen for suspected malignancy, what is the most appropriate action? A. Proceed with contrast CT without adjustment since her ECFA is not critical. B. Use gadolinium-based contrast instead of iodinated contrast. C. Administer iodinated contrast with pre- and post-procedure hydration and consult nephrology if needed. D. Avoid all contrast and suggest an ultrasound instead. Answer. Correct answer. C. Explanation. In patients with ECFA 45 mmN, particularly diabetics, there's increased risk of contrast-induced nephropathy, SIN. Current guidelines, e.d. RCR contrast guidelines, SR guidelines, recommend romanization pre- and post-contrast in clinical judgment about contrast necessity. Gadolinium may also be contraindicated due to the risk of nephrogenic systemic fibrosis NSF. Avoiding contrast might lead to suboptimal diagnosis. The safest course is hydration, risk assessment, and informed decision-making with nephrology involvement. Question 3. By evaluating the biodistribution pattern of 99 CMIP in a bone scan, what factor most reliably differentiates between metastatic lesions and degenerative changes? A. Symmetry of uptake in joints. B. Increased uptake in axial skeleton alone. C. Absence of renal visualization. D. Focal asymmetrical uptake in non-weight-bearing areas. Answer. Correct answer. D. Explanation. Degenerative changes typically produce symmetric and periarticular uptake in weight-bearing joints. In contrast, metastatic lesions often present as focal asymmetrical hotspots, particularly in non-weight-bearing areas like ribs, scapulae, and skull. Interpretation requires knowledge of tracer kinetics and anatomical correlation per BNMS guidelines and MMI practice standards. Absence of renal activity may indicate technical or systemic factors, but is not a reliable discriminator alone. Question 4. Dr. El Said is performing an EIDed lung biopsy on a patient with a 2.5 cm peripheral lung nodule. The patient is on aspirin 75 mg daily. What is the most appropriate pre-procedural management plan? A. Procedures plan. Aspirin doesn't increase bleeding risk. B. Stop aspirin for 7 days prior to the biopsy and consider bridging therapy. C. Continue aspirin but monitor platelet count closely. D. Cancel the procedure due to aspirin usage. Answer. Correct answer. B. Explanation. The RCR and BCR guidelines recommend withholding antiplatelet agents including aspirin 5-7 days before high-risk procedures like lung biopsy due to bleeding risks, e.g. hemothorax. Bridging is rarely necessary unless the patient has high thrombotic risk. Continuing aspirin may significantly increase bleeding complications. Platelet count monitoring does not mitigate the pharmacological inhibition caused by aspirin. Question 5. Which of the following practices best aligns with the ALARA as low as reasonably achievable principle in pediatric CT imaging? A. Using adult protocols with automatic exposure control. B. Reducing mass and KVP. while maintaining diagnostic quality. C. Eliminating shielding to avoid scatter reflection. D. Performing all scans without prior justification to reduce wait times. Answer. Correct answer, B. Explanation. ALARA is a cornerstone of radiation protection, especially critical in pediatrics who are more radiosensitive. Best practice includes tailoring protocols, reducing to current mass and voltage AVP while preserving image quality through iterative reconstruction and patient-specific protocols. Adult settings are excessive. Eliminating shielding contradicts protection goals. Imaging must be justified and optimized. IRMA 2017 Pediatric Imaging Guidelines. Question 6. Mr. Thompson, a 57-year-old man with acute confusion and left-sided weakness, undergoes an urgent non-contrast CT head. The radiologist observes early loss of insular ribbon and subtle hypodensity in the right imacae territory. What is the most appropriate next step? A. Delay imaging to report CT in 6 hours for confirmation. B. Recommend thrombolysis evaluation based on ischemic stroke criteria. C. Attribute findings to age-related changes and recommend observation. D. Suggest MRI brain without further comment. Answer. Correct answer, B. Explanation. Early signs of infarction on non-contrast CT, such as loss of insular ribbon, are critical for identifying hyperacute ischemic stroke. Prompt evaluation for thrombolysis e.g. Alteplase must be initiated if within therapeutic window 4.5 hours following NICE and RCR stroke imaging guidelines. Delay reduces chance of intervention. MRI is sensitive but may not be practical in emergencies. Question 7. In what ways can the silhouette sign aid in localizing pulmonary pathology on a chest radiograph? A. It differentiates obstructive from non-obstructive atelectasis. B. It confirms the presence of pleural effusion. C. It helps identify which mediastinal border is obscured, indicating lesion location. D. It determines whether a lesion is malignant. Answer. Correct answer, C. Explanation. The silhouette sign refers to the loss of normal borders between thoracic structures, e.g. heart diaphragm and adjacent lung fields, suggesting a lesion in contiguous anatomical segments. For instance, obscuration of the right heart border suggests pathology in the right middle lobe. This principle aids in segmental localization, but doesn't confirm malignancy or effusion independently. Felson's principles of röntgenology. Question 8. Optoling is reviewing an abdominal CT of Mr. Ramos who has abdominal pain. The axial slices show a rounded structure anterior to the eye and posterior to the pancreas head. Which structure is this likely to be? A. Aorta. B. Left adrenal gland. C. Third part of duodenum. D. Common bile duct. Answer. Correct answer, D. Explanation. The common bile duct CBD traverses posterior to the first part of the duodenum, passes behind the pancreas head, and lies anterior to the eye. It is a key structure assessed in hepatobiliary imaging. The aorta is midline and posterior to IV. The left adrenal gland is left-sided. The third part of the duodenum is posterior to the spine, anterior to aorta. Accurate anatomical knowledge is essential in cross-sectional interpretation. RCR anatomy modules. Question 9. Which artifact arises due to undersampling in MRI and how can it be minimized? A. Chemical shift, minimized by increasing bandwidth. B. Aliasing, minimized by using phase oversampling. C. Motion artifact, minimized by breath holding. D. Magnetic susceptibility, minimized by fast spin echo sequences. Answer. Correct answer, B. Explanation. Aliasing wraparound occurs when field of view FOV is smaller than the body part being imaged, causing structures to appear on the opposite side of the image. It's a result of undersampling in the phase encoding direction. Mitigation includes increasing FOV or using phase oversampling. Other artifacts have different causes and remedies are ERI, safety and quality guidelines. MRI may easy. Question 10. When analyzing a request for a lumbar spine MRI from a general practitioner for non-specific back pain without red flags, what is the radiologist's ethical obligation under the principles of justification and clinical governance? A. Proceed with the scan to meet referrer's expectations. B. Decline the request and report the GP to the medical board. C. Review the clinical details and reject or amend the request with explanation. D. Perform a EE-TED for faster imaging. Answer. Correct answer, C. Explanation. Under IRMA 2017 and RCR for guidelines, every imaging request must be clinically justified. Non-specific back pain without red flags does not warrant MRI. The radiologist should review and provide alternative guidance or decline with clear documentation, promoting evidence-based, ethical practice. Arbitrarily imaging exposes patients to unnecessary risk and cost without benefit. Question 11. MS Lara, 38, presents with abnormal uterine bleeding. A transvaginal ultrasound reveals an endometrial thickness of 14 mm and multiple echogenic foci within the endometrium. What is the most likely diagnosis? A. Adenomyosis. B. Endometrial carcinoma. C. Endometrial hyperplasia. D. Submucosal fibroids. Answer. Correct answer, C. Explanation. Endometrial hyperplasia often presents with diffuse endometrial thickening 12 mm in premenopausal women and may include echogenic foci due to glandular cystic dilation. In contrast, endometrial carcinoma tends to have irregular or heterogeneous endometrium, and submucosal fibroids are more focal with shadowing. Adenomyosis involves the myometrium and presents differently. Per RCR and FIGO guidelines, thickness and pattern are crucial. Question 12. A 72-year-old man on warfarin presents with gastrointestinal bleeding. His inner is 3.2 and an urgent CT angiogram confirms active arterial bleeding in the jejunum. What is the safest and most effective intervention? A. Surgical resection of the bowel. B. Conservative management with vitamin K. C. Endoscopic clipping. D. Transcatheter arterial embolization. T. After inner correction. Answer. Correct answer, D. Explanation. T is the preferred minimally invasive intervention for acute GERD bleeding after confirmation of arterial source on CT angiography. However, an inner 1.8 2.0 poses bleeding risk, so correction G with vitamin K or FFP is recommended before proceeding. Surgery is reserved for failed embolization or unstable patients. Endoscopy is first line for upper GERD bleeds, may not reach the jejunum effectively. Question 13. In RECIST 1.1 criteria for solid tumor assessment, which of the following constitutes a complete response? CR. A 30% reduction in the sum of diameters of target lesions. B. Appearance of new lesions without change in existing lesions. C. Disappearance of all target lesions and pathological lymph nodes. 20% increase in size of any lesion. Answer. Correct answer, C. Explanation. RECIST 1.1 defines complete response (CR) as disappearance of all target lesions, with pathological lymph nodes reducing to 30% reduction, and progressive disease (PD) is 20% increase or appearance of new lesions. Accurate response categorization guides treatment continuation or alteration in oncologic protocols. Question 14. Kumar, a 47-year-old male, presents with right upper quadrant pain. Ultrasound shows a thick-walled gallbladder with pericholecystic fluid and a positive sonographic Murphy sign. What is the most likely diagnosis? A. Gallbladder carcinoma. B. Chronic cholecystitis. C. Acute cholecystitis. D. Biliary sludge. Answer. Correct answer. C. Explanation. The triad of gallbladder wall thickening, 3 mm, pericholecystic fluid, and positive sonographic Murphy sign strongly suggests acute cholecystitis, especially with gallstones. Chronic cholecystitis typically lacks acute inflammation features. Gallbladder carcinoma shows mass-like features or wall irregularity. Biliary sludge does not cause acute inflammatory signs. Question 15. Which MRI feature is most characteristic of an osteoid osteoma? A. Marrow-replacing lesion with soft tissue mass. B. Hypointense nidus on tweighted images with central calcification. C. Nidus with high signal on tweighted images and surrounding bone edema. D. Diffuse marrow infiltration with cortical destruction. Answer. Correct answer. C. Explanation. Osteoid osteoma shows a small nidus 1.5 cm with T hyperintensity and marked surrounding bone marrow and soft tissue edema. CT often helps in identifying central calcification. Cortical destruction and diffuse infiltration suggest more aggressive tumors like Ewing sarcoma or metastases. Question 16. Amara, a parotid gland lesion in a 45-year-old man is hyperintensant, and shows intense enhancement with lobulated margins. What is the most likely diagnosis? A. Pleomorphic adenoma. B. Warthin's tumor. C. Parotid abscess. D. Mucoepidermoid carcinoma. Answer. Correct answer A. Explanation. Pleomorphic adenomas are the most common benign parotid tumors, typically showing T hyperintensity, load, and strong post-contrast enhancement with lobulated borders. Warthin's tumors are often T hyperintense and bilateral. Abscesses may show central non-enhancement. Mucoepidermoid carcinomas tend to be ill-defined and invasive. Question 17. A 21-year-old female in a road traffic accident has a pelvic fracture with ongoing hypotension. Fast scan is negative. What is the most appropriate next step? A. Immediate laparotomy. B. Pelvic X-ray and bind the pelvis. C. Wait and watch with Roman Huids. D. Diagnostic peritoneal lavage. Answer. Correct answer. B. Explanation. Pelvic fracture with hypotension and negative fast suggests pelvic source of bleeding. Initial management includes pelvic X-ray and pelvic binder to reduce bleeding by tamponade. Laparotomy is not first line without intraperitoneal hemorrhage. Peritoneal lavage is rarely used now due to availability of fast and C. Question 18. In a workup of suspected non-accidental injury (NIAN), a 2-year-old, which radiographic feature is most specific for abuse? A. Spiral femoral fracture. B. Superior steel new bone formation. C. Posterior rib fractures. D. Metaphyseal corner fracture. Answer. Correct answer. D. Explanation. Metaphyseal corner fractures, also called bucket handle fractures, are highly specific for non-accidental trauma resulting from twisting or shearing forces. Posterior rib fractures are also suspicious but less specific. Spiral fractures can occur accidentally depending on age and history. Superior steel bone formation may be seen in healing fractures or other conditions. Question 19. Isis Jensen, age 53, presents with a new palpable breast lump. Mammogram shows a spiculated mass with microcalcifications. What is the BI-RADS classification and recommended next step? A. BI-RADS 3. Follow up in 6 months. B. BI-RADS 4. Perform MRI. C. BI-RADS 5. Proceed to biopsy. D. BI-RADS 2. Benign finding. Reassure patient. Answer. Correct answer. C. Explanation. Spiculated margins and pleomorphic microcalcifications are highly suspicious for malignancy. BI-RADS 5 is used when there's 95% chance of malignancy, and core biopsy is the recommended next step. MRI may be adjunct but does not replace tissue diagnosis. Question 20. Which of the following best explains the streak artifacts seen in CT imaging when scanning metallic implants? A. Undersampling artifact from low detector array resolution. B. Beam hardening and photon starvation. C. Motion during image acquisition. D. Incorrect windowing settings. Answer. Correct answer. B. Explanation. Streak artifacts around metallic implants occur due to beam hardening. Lower energy photons absorb more and photon starvation, resulting in areas of high contrast discrepancy. Correction methods include metal artifact reduction (MAR) algorithms, dual entity CT, and adaptive filtering. Undersampling and motion cause different artifact types. Question 21. A 58-year-old male presents with progressive memory loss and personality changes. MRI shows frontal lobe atrophy greater than temporal and hyperintensities in the caudate head-on flare. Which is the most likely diagnosis? A. Alzheimer's disease. B. Normal pressure hydrocephalus. C. Frontotemporal dementia. D. Huntington's disease. Answer. Correct answer. C. Explanation. Frontotemporal dementia (FTD) typically presents with frontal temporal lobe atrophy and personality behavioral changes. Huntington's disease involves caudate atrophy but presents earlier 30s, 40s. Alzheimer's more prominently affects medial temporal lobes. NPH is associated with ventriculomegaly and clinical triad of gait disturbance, dementia, and incontinence. Question 22. A 25-year-old presents with acute shortness of breath. Chest X-ray shows a thin white line with no lung markings beyond it on the right hemithorax. What is the most appropriate next step in management? A. Needle aspiration in second X midclavicular line. B. Observe and repeat CXR in 6 hours. C. Insert chest drain in fifth X mid-axillary line. D. Immediate thoracotomy. Answer. Correct answer. C. Explanation. A visible pleural line with absent lung markings suggests a pneumothorax. In a symptomatic patient, the standard treatment is chest drain insertion of the safe triangle fifth X mid-axillary line. Needle aspiration is usually for primary spontaneous pneumothorax in stable patients. Thoracotomy is only for massive or recurrent cases. Question 23. Which of the following thyroid conditions shows increased uptake on a technetium 99 meters pertechnetate scan? A. Thyroiditis. B. Graves' disease. C. Toxic adenoma. D. Both B and C. Answer. Correct answer. D. Explanation. Graves' disease and toxic adenomas show increased uptake on radionuclide imaging due to autonomous or diffuse increased function. Thyroiditis shows reduced uptake due to follicular cell damage. Uptake patterns help differentiate hyperthyroid causes and guide therapy, g. Ryablation versus antithyroid drugs. Question 24. A 19-year-old athlete presents with acute knee pain following hyperextension. MRI shows bone bruise on lateral femoral condyle and anterior tibial translation. What ligament is most likely torn? A. Medial collateral ligament. B. Posterior cruciate ligament. C. Anterior cruciate ligament. D. Lateral collateral ligament. Answer. Correct answer. C. Explanation. Bone bruising on the lateral femoral condyle with anterior tibial translation is classic for ACL injury. The ACL prevents anterior translation of the tibia. PCL injuries cause posterior translation, while collateral ligaments result in valgus varus instability rather than anterior translation. Question 25. A 75-year-old male presents with painless jaundice. CT shows a hyperattenuating mass in the pancreatic head causing biliary duct dilatation. Which sign supports the diagnosis of pancreatic adenocarcinoma? A. Double duct sign. B. Target sign. C. Pseudokidney sign. D. Accordion sign. Answer. Correct answer. A. Explanation. The double duct sign, simultaneous dilatation of the CBD and pancreatic duct, is highly suggestive of pancreatic head carcinoma. Target sign is more common in intussusception or metastasis. Pseudokidney is for bowel wall thickening. Accordion sign is seen in C. diffuse Question 26. Which of the following best describes the ALARA principle in radiological practice? A. Use of maximum dose for best image quality. B. Use of minimum exposure time to avoid repeat imaging. C. Keeping radiation doses as low as reasonably achievable. D. Mandatory use of shielding for all patients. Answer. Correct answer. C. Explanation. ALARA as low as reasonably achievable is a core radiation safety principle encouraging dose minimization consistent with diagnostic quality. It encompasses using lowest dose shielding, collimation, and avoiding unnecessary studies. Mandatory shielding is part of ALARA but not equivalent to the principle itself. Question 27. A patient with known colorectal carcinoma undergoes CT for staging. A 2.5 cm hypodense lesion is seen in liver segmentometry with peripheral enhancement and central necrosis. What is the most likely diagnosis? A. Hepatic cyst. B. Hemangioma. C. Liver metastases. D. Focal nodular hyperplasia. Answer. Correct answer. C. Explanation. Liver metastases from colorectal carcinoma often appear hypodense with peripheral REM enhancement and central necrosis, especially in portal venous phase. Hemangiomas have peripheral nodular enhancement filling in centripetally. FH shows central scar with arterial enhancement. Simple cysts are uniformly hypodense and non-enhancing. Question 20. What is the primary imaging modality used to guide biopsy of a superficial neck lymph node? AET, B. MRI, C. Ultrasound, D. PET-CT. Answer. Correct answer, C. Explanation. Ultrasound is the preferred modality for superficial lymph node biopsy due to real-time guidance, no radiation, and high-resolution visualization. CT is used for deeper structures. MRI is less practical for interventional procedures. PET-ET is useful for selecting target nodes, but not for guidance. Question 29. A 32-year-old pregnant woman at 20 weeks gestation presents for an anomaly scan. Which of the following findings is most specific for a diagnosis of spina bifida? A. Lemon sign, B. Banana sign, C. Ventriculomegaly, D. Echogenic intracardiac focus. Answer. Correct answer, B. Explanation. The banana sign, cerebellar compression due to downward displacement, is highly specific for spina bifida. Lemon sign is less specific and seen earlier. A ventriculomegaly can be due to multiple causes. Echogenic intracardiac focus is a soft marker, not specific for neural tube defects. Question 30. Which T pattern is most suggestive of usual interstitial pneumonia? A. Ground glass opacities with central distribution. B. Subpleural reticulation with honeycombing. C. Centrilobular nodules and tree and bud appearance. D. Mosaic attenuation with expiratory air trapping. Answer. Correct answer, B. Explanation. Ewart pattern, typical of idiopathic pulmonary fibrosis, features subpleural reticulation, basal predominance, and honeycombing without significant ground glass opacity. Tree and bud is seen in airway diseases. A mosaic attenuation is more indicative of small airway or vascular disease. Central ground glass suggests other causes like hypersensitivity pneumonitis or INSIP.